Hello, my name is Professor Leanne Young, and I'm teaching the maternal and newborn nursing class for Fortis College. And this week we are going to be covering week 6 content, which includes our high risk intrapartum nursing care. Okay, so we're going to go ahead and dive into this PowerPoint here. So feel free to follow along, take lots of notes. This will cover the bulk of the content for week 6. So we're going to start off by discussing labor and delivery complications. So what is this all going to cover? We're going to cover preterm labor and birth, premature rupture of membranes, chorioamnionitis, post-term pregnancy, labor and birth, dysfunctional labor, or in other words, a dystocia of labor, obesity, obstetric procedures, and obstetric emergencies. So diving right in, we are going to start off by talking about preterm labor and birth. So in red, I have highlighted for you the definitions of both preterm labor and preterm birth. So, preterm labor is regular contractions along with a change in cervical effacement or dilation, or regular contractions and cervical dilation of greater than 2 centimeters at preterm gestation. Preterm birth is any birth that occurs between 20 weeks and 0 out of 7 days and 36 weeks and 6 out of 7 days. Weeks of gestation. It can be categorized as very preterm, which is when there's a delivery that occurs earlier than 32 weeks, moderately preterm, which is 32 to 34 weeks, and late preterm, which would be your 34 to 36 weeks of gestation. Okay. It is very important for your guys' exams that you understand the differences between very preterm, moderately preterm, late preterm, and what we consider a preterm delivery. Okay, anything earlier than 37 weeks of gestation, we would consider preterm. Okay, 15 million babies are born preterm every year. The highest instance in America is among Black mothers, African American mothers. One thing that we need to understand very, very well is our preterm birth versus a low birth weight, because these are very different things, okay? So preterm birth versus low birth. Preterm birth is describing the length of gestation, where low birth weight describes only the infant's weight at that time of birth. Okay. Occasionally, these terms have been interchanged, but that is not accurate. Preterm birth is a more serious and dangerous medical condition for newborns. Think about it. Less time in the uterus means an underdevelopment of vital body systems, right? Low birth weight babies can be, but are not always, preterm. Low birth weight can be caused by other factors. Okay, so low birth weight, what is our definition for that? Low birth weight is defined as a baby that weighs less than 25,000 grams at delivery. What are some things that can cause low birth weight? This is important for us to know. Intrauterine growth restriction. What is a very prime patient population that has a high risk of intrauterine growth restriction? Adolescent pregnancies, right? Because the number one thing we're worried about with adolescent is appropriate nutritional intake during pregnancy, and they can have an increased risk for intrauterine growth restriction. Okay, hypertensive moms. Those moms can also have babies that are small. And then just poor nutrition in general. We can see low birth weight. So that could be moms that have eating disorders, mom that struggles with anorexia, bulimia nervosa, or anything like that. They're going to be at a higher risk for having smaller babies because their nutritional intake is going to be poor, right? Okay. So low birth weight infants and preterm birth infants are not always the same thing. If you have a preterm birth, most of the time that baby is going to be small. However, you can have a low birth weight infant that's delivered at 40 weeks of gestation, okay? Because of IUGR, because of these other things that we're seeing with these moms and during their pregnancies, okay? So we need to know the difference there. We need to know they're not the same thing. On your slide, I also have spontaneous versus indicated preterm birth, okay? This is how preterm births can be categorized. Spontaneous preterm births occur following an early initiation of the labor process in moms and babies. They don't have any underlying medical problems or conditions. Spontaneous preterm births make up about 75% of all preterm births in the US. So, this is when mom is just going into labor on her own. She has no underlying medical conditions. There's nothing that's really indicating why she's going into preterm labor. It's just something that is happening and is a medical emergency, a medical condition. When we're talking about spontaneous preterm births, most of the time they are initiated by preterm, pre-labor rupture of membranes, which we are going to talk about that more in detail. Okay. So typically what happens is that a mom's water or her amniotic sac will break when she is preterm. Okay. What is an indicated preterm birth? An indicated preterm birth occurs to resolve maternal or fetal risk related to the pregnancy. Okay, this is something that medically has been indicated. So, mom has uncontrollable gestational diabetes. It has led to gestational hypertension, which has developed to preeclampsia, and she becomes eclamptic. She's having seizures. If the medical team thinks that the best course of action is to deliver her baby at 32 weeks of gestation rather than trying to manage her seizure activity and protect neurological development for both the baby and mom's neurological function, they may decide to take that baby early. Okay. Typically, if we are doing a preterm delivery, or we're inducing preterm, there has to be really substantial medical evidence as to why, because we don't want those babies to be born premature. The longer that babies can grow and stay in utero, the better. Okay. Causes are things that can indicate a preterm birth. Diabetes, hypertension, preeclampsia, cholestasis, whenever moms have those really itchy palms and those itchy soles of their feet. Any issues with the placenta can be an indicator that we need to potentially deliver preterm. Seizures, a thromboembolism, asthma, obesity, smoking, advanced maternal age, fetal disorders, or birth defects. Okay. What can cause preterm labor and birth? Page 415, box 17.2 lists like all of them for you. Okay, there are a lot of things that can cause preterm labor and birth. A big one is drug use. So if moms are abusing any type of like narcotic substances, cocaine, any illegal street drugs, that can sometimes cause preterm labor and birth. What are some risk factors that we can see that may indicate that moms are going to go into preterm labor and have an early baby? History of if they've had a history of preterm birth in the past. If they've had a baby before at 33 weeks gestation, we need to monitor this mom extra closely or carefully in her other subsequent pregnancies because she's at an increased risk for having another early baby. Bleeding of uncertain origin in pregnancy is a risk factor. Uterine anomaly, so if her uterus is a different shape or she has a bifocal uterus, that can be an indication that she might go into preterm labor. If she has twins typically will go earlier. If she had late prenatal care where we don't really know how her baby has been growing, we don't really know much about this pregnancy, that can be indicating that she could be at a high risk for preterm labor. If she has a lower socioeconomic status and limited education, it's because they may not know the signs and symptoms of preterm labor, preterm birth, or delivery. So these are things that we need to take into consideration whenever we see patients in the office. Okay. On your slide, I have here cervical length. So, cervical measuring can identify if a woman has begun the labor process. So, it's measured via transvaginal ultrasound. So, they'll use the transvaginal ultrasound probe and they'll go up into the vagina. They'll take a look at the cervix, they'll measure it. A woman's cervical length that is greater than 30 millimeters in the second and third trimester of pregnancy are unlikely to give birth prematurely, even if they have symptoms of preterm labor. Okay, so if a woman has suspected like weird bleeding throughout her pregnancy, she has a history of preterm labor, she's had a history of a stillbirth or an poor outcome in the past, a provider may want her to have a cervical length measurement done to rule out if she's at a high risk for preterm labor. Okay. If she has a cervical length that's greater than 30 millimeters, the chances of her going into preterm labor are very unlikely. Okay. If it is less than 30 millimeters or they're measuring and that cervix is short, she is at an increased risk for delivering prematurely, for going into preterm labor. So this would be a mom that they would see in the office every week to establish, okay, has your cervix gotten shorter? Are there signs that you're already going into labor? Should we give you progesterone to strengthen and um, give you medications to prevent you from going into preterm labor? That kind of thing. Those are going to be determined by the provider if they see or have any suspicion that this mom is at a high risk. Okay. Another one that we can use is a fetal fibronectin test. This is an additional diagnostic test to rule out preterm labor. FFN is a glycoprotein found in plasma and is produced during fetal life. It normally appears in cervical and vaginal secretions early in the pregnancy and then again in late pregnancy. The test is performed by using a swab during a speculum exam to collect fluid from the woman's vagina. The presence of fetal fibronectin during the late second or early third trimesters of pregnancy may be related to placental inflammation, which can cause spontaneous preterm labor. This is a test that is better used to determine who will not go into preterm labor rather than who will. Okay. So if these women, if we swab them and there is a presence of that FFN during that late second or early third trimester of pregnancy, that can give us a clue of, okay, this placenta may be a little bit inflamed. She is at a little bit increased risk for preterm labor. So we probably should go ahead and get a cervical length, be testing and monitoring her, get NSTs, and watch her carefully. Okay. So, as far as interprofessional care, what do we need to do as the nurses that are ruling out preterm birth and preterm labor? We need to prevent, okay? We need to address the risk factors that moms have. Um, we need to educate moms, specifically moms that are using any type of heavy drug during their pregnancy or smoking or introducing any type of teratogens into the pregnancy during the antepartum period. We need to help them finding a resource in stopping that behavior. Okay, because that puts them at a much higher risk for preterm birth and preterm labor. And preterm deliveries for infants is high risk situation. They're in the NICU for a while. They're monitored very closely. They can have some lasting complications throughout their life as a result of being born preterm. So these are things that we really want to try and prevent. Okay. We need to educate and educate and educate these patients when they come in, especially patients who have had a history of preterm deliveries before, have a family history of something like that, have seen it or worried about it, are having weird uterine contractions or weird symptoms during their pregnancy, are at a high risk or have a high risk pregnancy. We need to be telling them, okay, here are your signs and symptoms of labor. If you feel or notice any of these things, you need to immediately go to the OB department, go to the emergency room, and you need to be evaluated, right? Because if they are in preterm labor, we have medications available that can stop it for a short period of time. We have medications that can delay it. And we also have care measurements in place for these kinds of instances. I mean, now there are women who have gone into labor and have delivered a 23-week-old baby, and that baby has survived because they have early recognition and early intervention. Okay, so that's important. We need to evaluate patients for the indication of progesterone administration. So, progesterone, we talk about progesterone and estrogen a lot whenever we're talking about labor and delivery or OB pregnancy. Progesterone. So, in preterm birth, this can be prevented in some women by prescribing progesterone. Daily vaginal suppositories, creams, or weekly intramuscular injections of 17-alpha hydroxyprogesterone caprate have been shown to decrease the rate of preterm birth by about 40% in women with a history of it, or those who have a short cervix before 24 weeks of gestation. Mainly used in women with short cervixes, right? So, like I said, if that cervix is measuring less than 30 millimeters, or it's measuring really short early on in the pregnancy, We can give progesterone to help strengthen that cervix and prevent it from dilating and effacing and sending these women into labor. So, typically, if we're going to do progesterone therapy, it begins at 16 weeks and it continues until 36 weeks of gestation. So, if a woman has had a preterm delivery in the past, they are going to be a candidate for progesterone treatment during subsequent pregnancies. That is going to be completely up to the provider. It's going to be based on the surrounding factors of why that woman had gone into preterm labor with her last delivery. Okay. So, like we said, another thing that we need to do is we need to have early recognition and diagnosis. So we need to transfer that mom if it's indicated. If a mom comes into a labor and delivery unit and she is 28 weeks gestation, she is just now into her third trimester. She is laboring, she's contracting, she's dilated to 5 centimeters, and you're at a small hospital that has no resources. We need to get a NICU team there because she's not going to be stable enough for transport. And we need to do antibiotics, administer those glucocorticoids, right? That betamethasone, celestone, that helps with baby's lung development, fetal lung development. We have to administer that as quickly as possible and initiate mag therapy. Why are we initiating magnesium therapy in a woman who has progressed in her labor and does not necessarily have high blood pressures? We talked about this in week 5, the real reason that we're using magnesium. Not only for maternal seizure precaution, mag therapy helps protect fetal brain neurological function. It protects specifically against cerebral palsy. Okay, so if you're administering magnesium therapy when a woman is in labor, it helps the baby's brain develop, it helps protect their neurological function, and specifically helps against cerebral palsy development. Okay, what are our signs and symptoms of preterm labor? You guys need to star circle, know this stuff like the back of your hand, okay? Signs and symptoms of preterm labor. If a mom says that she's having a change in the type of discharge, so she tells you, all throughout my pregnancy, my discharge has been kind of like clear, like mucusy, like normal, just like normal vaginal discharge, but just a little bit extra of it. And now she's telling you my discharge is like really runny, it's watery, it's got kind of a weird color to it, it smells kind of weird. Like that should be an indicator to you, like, okay, we probably should do a swab and figure out what this is. Okay. If she has an increase in the amount of vaginal discharge, if she's having pelvic or lower abdominal pressure, a constant low, dull backache, mild abdominal cramps with or without diarrhea, contractions, or if her water breaks. Those are all signs and symptoms of preterm labor. Okay. Some things that we can tell moms to do to prevent preterm labor, especially in women who have had a history of it in the past. We need to put them on specific restrictions. So, activity restrictions. These women should not be going out and doing CrossFit every day. Okay. An increase in the amount of activity, especially in the third trimester, can sometimes lead to preterm delivery, preterm labor. So, we want to have them modify their lifestyle and have them modify their exercise regimen. They should be on pelvic rest at a certain point, if not at the entire pregnancy. So, no sex. Um, these patients are also candidates potentially for prolonged hospitalization, depending on if their cervix is making change, if the baby is still stable, if their water is still intact. If any of these things are happening, but they're also still showing signs and symptoms of preterm labor, these patients might be hospitalized for a long period of time to finish out their pregnancy in a safe way and get baby to the highest amount of gestation that we can get them to. Okay, so let's talk about tocolytics or uterine relaxants. These are medications that we can give to suppress uterine activity, slow down contractions, okay? So like I have here, the definition, tocolytics are medications given to arrest labor after uterine contractions and cervical dilation has occurred, okay? One of them is magnesium. Um, Magnesium sulfate is the most commonly used tocolytic agent. Maternal and fetal adverse reactions are typically less severe when magnesium is in use. So it's a good option whenever we're trying to relax that uterine smooth muscle and prevent moms from having contractions. Is magnesium always effective in slowing down labor? No. If a mom is already in labor, she's in labor. Okay. There's not very much that's going to slow it down. Same with all of these. Okay. If mom's body is ready to have this baby, she's going to have this baby. So we're going to give these medications in order to try and prolong her labor so that we can get NICU team there, so that we can potentially transport mom to a higher level of care facility. But if mom is already in labor, she's already going to be delivering here sometime soon. Um, we need to prepare for imminent delivery if that's the case. Okay. Terbutaline is a very popular tocolytic. It relaxes the smooth muscles by stimulating the beta 2 receptors in the uterine smooth muscle. It's given sub-Q. The dose is typically 0.25 milligrams. Okay. You cannot use two of these at a time, at the same time. So if you're putting a patient on magnesium, it is often contraindicated to administer terbutaline as well because you can cause more damage because you're administering medications that effectively are doing the same thing. Okay. A common side effect of terbutaline is increased fetal heart rate, increased maternal heart rate. Okay. What I always tell my patients if I'm giving them terbutaline is you're going to feel like you just drank 3.5, 4 cups of coffee. Like it feels like you just took a shot of caffeine straight into the vein. Okay. They're going to say they're going to feel anxious. They're feeling more irritable. They're feeling just like restless. They're feeling like their heart's racing and it's going to pound out of their chest. That is a side effect of terbutaline. And moms typically are very, very uncomfortable when we administer this medication. Fetal heart rate is going to be elevated after administering terbutaline as well. So if you have a mom who came in and she's been contracting and she's only 33 weeks of gestation and your provider tells you, okay, go ahead and administer terbutaline. We're going to try and slow these contractions down. Let's give her a fluid bolus because as we know, contractions can be caused by dehydration. So let's do all these interventions. Let's see if we can stop this labor. Um, and then you're going to need to keep that baby on the monitor for at least an hour or two after you administer the terbutaline because you want to make sure that that fetal heart rate returns back to its normal baseline. Okay. The third medication on here is nifedipine. It is a calcium channel blocker that will suppress contractions. It works by preventing calcium from entering the smooth muscle cells, which reduces contractions. Should not be given to any woman with infection, hypertension, or cardiac disease. Okay, just know that about nifedipine. That's important. Indomethacin is another one. This is an NSAID that suppresses labor by blocking the production of prostaglandins. This one we don't use as often because then it can have some pretty serious maternal side effects. Okay. We also, like I said, we need to promote our fetal lung maturity. We talked last week about celestone and betamethasone. It's the same thing. These are medications that are going to help with fetal lung development, and we should be administering them pretty quickly upon mom's admission, and then 24 hours later, giving her that second dose. Okay, this is to protect fetal lungs and lessen the amount of time that they have to spend in the NICU. Okay, for respiratory distress. Okay, so your mom is in here. She's 7 centimeters dilated. She's 30 weeks pregnant. She's about to have this baby. It is an inevitable preterm birth. If birth is expected within 24 hours, here's what we need to do. We need to administer mag sulfate for fetal neuroprotection, like we talked about. And that's typically given to women at least 24 weeks, but less than 32 weeks. Those are some things that we need to do. We need to give her that magnesium. If labor has progressed to a cervical dilation of 4 centimeters or more, we need to prepare our room for a small, immature neonate. Get your team to your room. Get the respiratory therapist. Get your pediatrician. Get your NICU team. Get your squad there if you're at a smaller hospital. Anybody that you can get in the hospital to help you prepare for the delivery of this baby, they need to be there, okay? I had a mom who came in. She was going to be delivering twins, and she started going into labor, and she was 29 weeks gestation, okay, with twins. So you can imagine a 29 weeker singleton pregnancy, that baby is maybe 2 pounds at that point. Okay. Um, so that is a very high risk neonate. Imagine there being two of them. So these babies are tiny and they're twins. They're early, specifically early eat for any baby, nonetheless twins. So what we ended up doing is we administered our tocolytics. We were giving mom Mag. She was only 5 centimeters dilated, but this was her seventh pregnancy or something like that. So I called the NICU, the squad transport line, and said, we're going to have a mom that's delivering at 29 weeks down here. We are not equipped to handle an infant of this size. We need a squad sent down here for the delivery of the baby. And the squad came and they sat on our delivery center until mom delivered so that they could be present and take care of those two babies because they're so small, okay? That was best case scenario. That's not how it always shakes out. But if you are anticipating an imminent delivery of a preterm baby, you should have your team or your resources there for you. Okay. Prepare for a malpresentation. So, this is more common in preterm births, right? A smaller baby can move around still in the womb in gestation and change position way more frequently than a, 35 to 40 week pregnancy. So it's oftentimes that these babies are born breech or these babies are born with a malpresentation. So we need to be prepared for that. Okay, so unfortunately, whenever we talk about preterm delivery, whenever we talk about preterm labor, we have to discuss neonatal loss, fetal and early neonatal loss. In the case of fetal demise or anticipated fetal demise following birth, we have to provide sensitive care, right? It is very hard to lose a loved one. It's very, very hard to lose a baby. So we need to be mindful of that. We need to discuss management plan with the interprofessional care team. How much intervention do these parents want, right? If a mom is delivering at the age of viability, right? So like 24 weeks, I think is what they're saying now. If mom is viable, if baby is viable, does she want us to do all of the interventions? We need to talk with her about the risks associated with preterm deliveries for the newborn. We need to ask their preferences on what they want to do. Okay. Do they want this baby to be given the full resuscitation efforts by our team? If the baby comes out without a heartbeat, what would you like us to do? If the baby comes out with a heartbeat, how would you like us to proceed? Those kind of things, okay? Um, it is always up to and at the discretion of the delivering parents, the parents that are having the baby, okay? Uh, if mom and dad decide that they would like to proceed with palliative care, we're going to put baby skin to skin with mom if that's what she prefers. Um, we need to make sure there's as few people in the room as possible. So just yourself and usually the delivery provider if you are that nurse in that room. We usually have a sign that we hang up outside of the door that has just a little symbol on it that lets people know that inside there is a fetal demise and not to go in without the permission of the nurse or the provider that's taking care of that patient. Um, we need to move the patient to a quieter part of the unit. So if a patient has just delivered and she had a stillborn, we are not going to be putting her right next to the nursery where she's going to hear babies crying all night long. Okay. That is just not what we're going to do. We're going to keep her in her own little area, quiet, removed from others in the hospital, and ensure privacy is maintained. Okay. And overall, we're just going to be very sensitive and handle this situation delicately because it is very traumatic. It's sad. I've been in a lot of deliveries with stillborns and early and late neonatal loss, and it is never easy. People handle this very differently. There's a huge cultural component whenever people are handling neonatal loss. Some cultures are very expressive and cry and they want to hold their baby, they want to hug and love on their baby. Other cultures are very stoic and they don't want really too much to do with the newborn, okay? So, and that's all right. Any way that people cope is the way that they cope, and we need to be respectful of that. Okay, next complication that we're going to move on to is premature rupture of membranes. So, I have two definitions up there for you that you guys need to know. Pre-labor rupture of membranes, or PROM, is the spontaneous rupture of the amniotic sac before the onset of labor at any gestation. Okay, so pre-labor, right? This mom is not in labor and her water breaks at any gestation. It doesn't matter how far along she is. Preterm pre-labor rupture of membranes, or PPROM, is the membrane rupture before 37 and 0 out of 7 weeks of gestation. Okay, so that's when a mom's water breaks if she's earlier than 37 weeks. Risk factors. Anything that may cause increased amniotic pressure. Polyhydramnios. If a woman has excessive amount of water or fluid, she is going to have an increased risk of preterm or pre-labor rupture of membranes. Same with a macrosomic infant that's a big baby. Same with twins, multiple gestation, or if mom is having a version done, like that baby is breech and she's trying to turn it head down so that she can deliver vaginally, we run the risk of rupturing her membranes sooner than what they may have done on their own. Okay. Infections of the urogenital tract. So there's some risk factors listed for you here. A short cervical length, second and third trimester bleeding, low socioeconomic status, a low BMI, and cigarette and drug use. They're all going to give the increased risk of the pre-labor or preterm rupture of membranes. Okay. What is our greatest complication with preterm rupture of membranes? Chorioamnionitis is the most common maternal complication of PP-ROM. This is a serious complication of pregnancy that we will discuss on the next slide. Other complications include placental abruption, retained placenta, sepsis, and potentially maternal or fetal death. Okay, so this is something that we need to get examined very quickly. Interprofessional care. How do we care for this? How do we care for a woman who comes in whose water has broke early? If the gestational age is greater than 37 weeks, delivery of the infant is the best option, okay, spontaneous or induced. So if a mom comes in and she's like, my water broke, I'm only 37 weeks and 2 days, I'm not having any contractions, we're going to have to induce her labor because at that point in time, it's safer for the baby just to be born than it is for us to sit on it, okay? The case must be made on an individual basis for pregnant women who rupture between 32 and 37 weeks. Okay. Usually it's dependent on fetal lung maturity and infant size. Okay. So if a woman comes in between 32 and 37 weeks and says, my water broke, and we do the test and we confirm, yes, this is amniotic fluid, your water has broke, we need to decide how big is your baby? Have you received celestone or betamethasone? Should we keep this woman on MAG for a couple days before we induce her labor? Should we give her antibiotics? Should we try and keep this baby in utero for a longer? It's going to be on an individual case by case basis. Okay. Prior to 32 weeks gestation is managed conservatively. Women are often hospitalized and continuously monitored in an attempt to prolong the pregnancy and allow for the infant to mature. Antibiotics, glucocorticoids, fluids, bed rest, activity rest, and magnesium administration is typically what happens. Any bleeding, infection, or other abnormal symptom may call for immediate delivery of the infant with resuscitation team on standby. So any woman whose water breaks earlier than 32 weeks gestation is going to be hospitalized long term to try and get this baby to mature, keep this baby in utero as long as possible, and administer these medications for them around the clock. So we talked about chorioamnionitis as being our biggest complication of preterm rupture of membranes. This is a bacterial infection of the amniotic cavity. Okay, it is diagnosed by maternal fever, tachycardia, uterine tenderness, and purulent amniotic fluid. It typically happens after rupture of membranes because some type of infectious agent would have had to been introduced to that amniotic cavity. Risk factors for chorio include a long labor. So if a mom's been laboring for a really long time, if she had those prolonged rupture of membranes, so her water has been broke for usually typically over 48 hours, we start to worry about chorio. If she's had lots of vaginal examinations, That is a risk factor because that is introducing that bacteria up into that vaginal canal, which can go and lead up to that amniotic cavity. If she has had internal fetal heart rate monitors, so those fetal scalp electrodes or that intrauterine pressure catheter, she's going to be at an increased risk for chorioamnionitis. Other factors could be a young mom, lower socioeconomic status, nulliparity, if a mom has never delivered a baby before. If she's had a cerclage, so whenever the provider goes up and stitches closed the cervix, that can lead to chorioamnionitis. If she had an amniocentesis early or late in her pregnancy, and other invasive OB procedures. Pretty much anything that could potentially introduce bacteria into the amniotic cavity is a risk factor for chorio. Okay. Complications. Women can develop bacteremia, and they're more likely to have a dysfunctional labor, and their risk for a C-section increases. As far as a newborn, what are the risk factors or complications for these newborns? They can develop pneumonia, bacteremia, meningitis. It also puts them at an increased risk for respiratory distress syndrome. Okay, moving on. We're going to talk now about postpartum pregnancy, labor, and birth. So, postpartum pregnancy is a pregnancy that reaches 42 weeks of gestation or more. What are we most worried about with these patients? Think about it. They've been pregnant for a long time. Is that placenta going to be functioning at its normal capacity? No, we're worried about placental deficiency because at the time when we get to that far along, we're worried about lower estrogen production. Okay, so we're worried about placental deficiency. Risk factors for a post-term pregnancy include this being a woman's first pregnancy. She's had a prior post-term pregnancy. Baby boys, for some reason, like to stay there a little longer. Obesity or a genetic predisposition. Clinical manifestations include moms start to lose weight, their uterine size will decrease, they may have some meconium in the amniotic fluid, which indicates that baby was stressed out at one point, and then advanced bone maturation of the fetal skeleton. So that baby's skull is going to start to like fuse together a little bit more because they're still growing, they're still developing in utero, right? So, what are some maternal risks with postpartum pregnancy? Severe perineal injuries. If you have a longer gestation, typically your baby is still growing, hopefully, throughout that entire time. So you have the risk of delivering a really big baby, which can increase the risk for severe perineal injury. Postpartum hemorrhage is increased as a result, chorioamnionitis, endomyometritis, cesarean birth, fatigue and physical discomfort, and then abnormal fetal growth. So a big baby, macrosomia. Fetal risks associated with postpartum pregnancy would be oligohydramnios, meconium aspiration, post-maturity syndrome. What is post-maturity syndrome? You guys will need to know this. 10 to 20% of infants are born post-term. What we can see with them is they may have a decreased amount of subcutaneous fat. They may lack that languio and vernix. So they may have some dry, cracked, peeling skin, long nails. They may have some mech staining of the skin, nails, and umbilical cord. Okay. Those are all things that are associated with post-maturity syndrome. How are we going to care for this patient that's post-term? We're going to increase the surveillance of the infant and mom. So if a mom goes over 40 weeks gestation, they are going to want to see her in the office at least once, if not twice a week. Mom needs to be doing fetal kick counts. We need to stress this with her. At any point after 28 weeks, we're telling them to do their fetal kick counts, but especially when they're over 40 weeks, whenever they are considered post-term, we need to have them be doing their fetal kick counts. Why? Because we're worried about placental insufficiency or placental deterioration. So with a deteriorating or deficient placenta, we're worried about fetal oxygenation, right? Because the placenta is what's supplying our oxygen to our babies. So we need to encourage mom to keep counting those kicks, keep counting those movements. Okay, dysfunctional labor, or another word that you guys are going to hear that means dysfunctional would be dystocia. Okay, dystocia is the lack of progress in labor for any reason. Dysfunctional labor is long, difficult, or abnormal labor. Okay. The main causes: ineffective uterine contractions or maternal pushing effort. Think about our power. Think about our primary and secondary powers. Does she have a hypertonic or hypotonic uterus? What do her contractions look like? Is there a change in the pattern of her contractions, of progression of the infant through the birth canal? Okay. Maternal anxiety, hyperventilation, and loss of control can impact the labor process, right? For our secondary powers, is mom pushing effectively? Is she pushing very well, or does she have a really heavy epidural and she can't feel anything down there? She can't even feel when she's having a contraction when to push. Okay. She might need an assisted birth, whether that's a vacuum or forceps or whatever it may be, which we will talk about those two things here soon. Fetal causes would be abnormalities of presentation, position, or development. Think about our passenger. So this is why when we talk about dystocia or dysfunctional labor, we go back all the way to our 5 Ps of labor. Okay. So that's why we teach you about those. One big thing is cephalopelvic disproportion. Is that baby's head not fitting correctly in the mom's pelvis? Is it not descending through the vaginal canal effectively because of cephalopelvic disproportion? Alterations in pelvic structure, so think about our passage, the shape and size of the bony pelvis, effectiveness of tissues, of soft tissues during pushing. All of the things that we had mentioned with our 5 Ps of labor come into play when we talk about dystocia of labor. Continuing on, when we talk about the alterations in pelvic structure, pelvic dystocia. This can occur whenever there are contractures of the pelvic diameter that reduce the capacity of the bony pelvis, including the inlet, mid-pelvis, outlet, or any combination. These contractures can be caused by congenital abnormalities, maternal malnutrition, neoplasms, or lower spine disorders. Okay. Soft tissue dystocia. So this is all falling underneath that window of pelvic structure. So soft tissue dystocia is the obstruction of the birth passage by an anatomic abnormality. So placental previa, if the mom's placenta is growing over that cervical os. Any uterine fibroids, if she has an ovarian tumor, a full bladder, or rectum will cause obstruction occasionally. Okay. So has mom been constipated for like 3 days before her labor? She might have a lot of stool backed up in her bowel. And sometimes that stool can get in the way of the fetal head and not allow for fetal head descent. Okay. Also, cervical edema may cause this. If baby's head is coming down in a weird shape or in a weird way, it's engaged on the cervix incorrectly, mom may not be pushing on a fully dilated cervix. That cervix could have gotten swollen during labor and not gone away completely. And that's very dangerous because it can cause cervical lacerations, right? In continuation, so our fetal causes, anomalies. So is that baby big? Is that baby have any like type of ascites and a tumor, an open neural tube, hydrocephalus, like cephalopelvic disproportion? Okay, that's a big one. This is the disproportion between the size of the fetus and the size of the maternal pelvis. The infant cannot fit through the maternal pelvis to be born vaginally, and it's usually due to fetal size and malpresentation. Okay. Is this baby in a bad position? The most common is persistent occipito-posterior position, so that OP, occipito posterior, OP presentation. This is present in 20% of labor. In this position, second stage of labor is prolonged. The mom is going to have back pain, a really weird contraction pattern, and that's something that can slow down or cause labor dystocia. Malpresentation or a multifetal pregnancy. So malpresentation is when something other than the fetal head is the presenting part. Breech presentation is the most common malpresentation. This form of presentation is associated with multifetal gestation, preterm birth, fetal and maternal anomalies, polyhydramnios, oligohydramnios. High rates of breech presentation are also present in infants with congenital abnormalities. Why is this going to cause dystocia? Because it does not apply adequate pressure on the cervix for effective dilation. Think about it. Your butt is a lot softer than your head. right? So a head pushing down on the cervix is going to cause effective change. A butt pushing down on the cervix is not. Okay. Position of mom, that can sometimes cause labor dystocia. So we need to let moms move and reposition the way that they feel like they need to. Typically, moms are going to move into a position that's going to help that baby descend through the vaginal canal. Okay. And then finally, our physiologic responses. This can have an effect on labor dystocia or on an effective labor, like we talked about those 5 Ps. So, hormones and neurotransmitters released in response to stress, your catecholamines, can cause a dysfunctional labor. Okay, so that's why we want to help moms with coping through their labor and coping through their contractions. All right, we're going to talk here quickly about precipitous labor. This is labor that lasts less than 3 hours from onset to time of birth. It is really, really fast labor. Okay. Fast labor, while for a mom is probably awesome. And they're like, woohoo, I just had the fastest labor ever. I'm feeling good. I just had this baby in 3 hours. It can cause a lot of complications postpartum. Okay. From the baby's standpoint, hypoxia can occur, intracranial pressure due to rapid birth. So they could have some brain or skull injury because of how fast they descended through the vaginal canal. Okay. Maternal complications. We're worried about uterine rupture. That uterus worked overtime. Like that uterus was working hard, even for just that like short, short period. Okay. That can cause a tired uterus. It can cause a rupture, and we need to be careful. Lacerations can occur with a precipitous labor because that mom is pushing that baby out so fast, we can tear her bottom. Okay. Sometimes precipitous labor will also cause an amniotic fluid bolus or embolus, sorry. And that is a maternal complication that we're going to talk about on the end towards the end of this slide. Um, a big one with precipitous labor or really fast labor, we run the risk of having a postpartum hemorrhage. Okay, that one you guys need to make sure you know. Hypertonic contractions, right? Just too many contractions all happening at the same time. When we think about that, we will go back to our talking about our fetal heart rate tracing. If you have too many contractions that are occurring all at the same time, is that baby being adequately oxygenated? No, they are not. So that's why we run the risk of developing hypoxia, right? Hypertonic contractions, too many contractions, can also cause placental abruption, uterine tachysystole. Some things that we see with that could also be like cocaine use. If a woman used cocaine during her pregnancy, we sometimes will see hypertonic contractions. So these are some things we need to know about precipitous labor. How do we care for a mom whose labor is not progressing the way that she wants it to or the way that we want it to? We need to do an initial and we need to continue doing an ongoing physical and psychological assessment of our patients. We need to monitor continuously how labor is progressing, whether that's performing vaginal exams if it is appropriate to do so, watching the fetal heart rate tracings, monitoring the fetal heart rate and contraction pattern, seeing how baby is progressing through the vaginal canal, and then helping moms cope with labor. So we need to observe for common problems. We need to reduce the risk of potential injury to both our mom and our baby, reduce maternal anxiety because, as we said, a psychological component can contribute to labor dystocia. We need to make sure mom is coping adequately with her labor. And then we also need to monitor for a potential for impaired self-concept as a parent. So we need to monitor and make sure that this mom is not feeling discouraged during her labor if it's not going the way that she wants it to. Okay. A mom has labored, she's 10 centimeters dilated. We're not progressing any further. She's been 10 centimeters for the last 4 hours. She's tried pushing for the last 4 hours. We're most likely going back for a C-section. If a mom has had it in her brain that she's going to have a vaginal delivery, and then she's being told right as she's at the end of her labor that she's going back for a C-section, that is going to impact her self-concept or her self-image. And we need to, as a nurse, reassure her and tell her, listen, what you are doing is harder than delivering just a vaginal birth and having it the way that you wanted it to. You are being selfless enough to give up something that you wanted to ensure the health and safety of your baby. And that is more important. Okay? We'll talk briefly about weight gain during pregnancy. The more a woman weighs, or prior to her pregnancy, the less weight she should gain during her pregnancy. So if she's morbidly obese, she should only be gaining about 11 to 20 pounds. Okay. And so on and so forth. You guys can read this slide. Okay. Um, Obesity is a high risk for spontaneous abortions and stillbirths. Okay. It also has an increased risk for fetal abnormalities and congenital deficits, and we will most likely need to induce labor in this population of women. Okay, let's start talking about our obstetrical procedures. So, one that we see a lot is aversion. I kind of mentioned this a little bit earlier whenever we were talking about preterm rupture of membranes or pre-labor rupture of membranes. Aversion is the turning of the fetus from one presentation to another. It may be performed externally or internally, which is very rare, by an OBGYN. Typically, if women are getting aversion, it's to turn their babies from being breech and turning them into being head down or cephalic. Okay. It's typically attempted about 36 to 37 weeks of pregnancy. What are contraindications to aversion? Ooh. Versions can be contraindicated if moms have any type of abnormality with their amniotic fluid, if they do have a high risk of preterm labor, if they're not 36 to 37 weeks of gestation, because a main side effect or complication that we see is an emergent cesarean delivery because of fetal intolerance to the version. So we need to make sure that the baby's at an appropriate gestational age if delivery was going to need to happen immediately after the version takes place. What are some things that we need to consider whenever we're getting patients ready for a version? We need to monitor that infant and mom before, during, and after the procedure. The ultrasound needs to be present for the OBGYN to use as a reference. We need to have a surgical team on standby for a stat C-section because, like I said, a complication of an aversion is fetal intolerance. So sometimes they need to be rushed back for a stat C-section after. If Rh immunoglobulin is needed, we need to administer this prior to the procedure. Make sure that mom gets her RhoGAM. Okay, let's move on here and talk about inductions of labor. Inductions are something that you guys are going to need to know definitely about for your exam. This is the chemical or mechanical initiation of uterine contractions before their spontaneous onset to bring about birth. It's basically putting a woman into labor. Okay. An elective induction, or so we split them typically into two categories, elective and medically indicated. An elective induction must occur at or after 39 weeks of gestation. This is whenever mom does not have any medical indication. Typically, moms are asking for one, and it's typically up to the provider if they're going to be willing to do an elective induction on a woman at 39 weeks. And at their own convenience, okay? An important thing to know whenever we're talking about elective inductions is calculating a woman's Bishop score. You guys will need to know how to calculate a Bishop score. You need to know what a Bishop score is. Bishop score. So this is what is going to indicate whether or not the success rate of a labor, okay? So success rates for induction of labor are higher when the condition of the cervix is favorable or inducible, okay? Cervical ripeness is the most important predictor of successful induction. A score of 8 or more indicates that the cervix is soft, that it's anterior, that it's 50% or more effaced and dilated 2 centimeters or more, and then that presenting part is engaged. This means that vaginal birth and induction are most successful, okay? On your slide, I have a picture here of how to calculate a Bishop score. So what are the categories? Cervical position, where is that cervix at? How soft is the cervix? Is she dilated or effaced? And then how low is baby's head? All of these things are going to give you a number. And if it's greater than 8, that means that mom has a favorable cervix for an induction. If it's less than 8, it means that her Bishop score is not favorable for an induction of labor. Okay? How do we induce labor? What are some things that we give moms, or what are some things that we do to get her labor started? So main ones would be cervical ripening methods or prostaglandins. Prostaglandins have proven to be the most effective to ripen, aka soften and thin the cervix. In some cases, women may only need a few doses of Cytotec. Okay, Cytotec is our go-to prostaglandin. Cytotec is less expensive, it's easy to administer, and has a quicker onset of action. Cytotec, the only thing that we're worried about with Cytotec is it has a high risk for uterine tachysystole because once we've placed this medication, we cannot take it away. We can't stop it because typically it's given either sublingually or vaginally. Okay, so those are your cervical ripening methods or your prostaglandins. Mechanical methods of induction. The biggest one that we see a lot on the floor is the balloon catheter or Foley catheter. Balloon catheters are inserted by the primary care provider through the cervix to ripen and dilate the cervix. So what happens is they're going to inflate a balloon. It's a Foley. They're going to put it up through the cervical opening. They're going to inflate a balloon with 30 to 50 milliliters of sterile water and then let it just sit on that cervix. Okay? They're going to allow it to open, that cervix to open, dilate, and stretch. The balloon will fall out typically whenever a mom or a woman reaches 4 centimeters of dilation. Okay. Let's see. Alternative methods that aren't typically used like in the hospital are blue cohosh, castor oil, and evening primrose oil. These are some things that women will typically do at home to start their labor before they go into the hospital or to try and get their labor going. Okay. What is an amniotomy? So, amniotomy is just the fancy word for an artificial rupture of membrane. Whenever a provider goes in with an amniotic hook and breaks a woman's water. This can be a method used by the primary care provider to induce labor if the cervix is ripened. Our biggest risk associated with an amniotomy is chorioamnionitis. Okay. What are our contraindications for an induction? If baby is in distress, if a mom comes in for a scheduled induction and that baby's fetal heart rate looks terrible and the strip looks bad, she's most likely going to just get a C-section because we don't want to stress that baby out by anymore by adding contractions on top of everything. If the baby has a malpresentation, if the baby's head is not well engaged to the cervix, if mom is bleeding, or if she has a placenta previa, we are not going to be inducing her labor. Okay. The other thing we talk about whenever we're talking about induction of labor is Pitocin. We use this a lot for inductions of labor. It's a hormone, as you guys know, that's normally produced by the posterior pituitary gland. It is going to stimulate uterine contractions and aid in milk production. Why do we use Pitocin? Because it may be able to induce labor or augment labor that has already started and has slowed down, or just to give moms contractions if we're just inducing them, elective or medically indicated. The goal is to produce contractions of normal intensity, duration, and frequency using the lowest dose of medication possible. What is our safe dose of oxytocin in labor? The starting dose of 1 milliliter per minute, milliunit per minute, and increase by 1 to 2 milliunits per minute every 30 minutes. But this is different for every provider. So some providers may say, okay, start your pit at 2, increase it by 2 every 30 minutes. Others might say start it at 1, increase it by 1 every 15. It really is provider indicated. What are contraindications to using IV Pitocin? If mom is having a placental abruption, we're not going to give her any other medications. If she's had a uterine rupture, if she's a C-section patient, she's having a postpartum hemorrhage, or if she has an infection. Okay. For babies, if the baby is already showing signs of fetal respiratory distress, we're not going to give we're not going to give oxytocin. Like I said, one of the things that our interventions whenever we're administering medications in labor is the first thing we're going to do is stop that Pitocin if baby starts to decline. Okay. What are some nursing considerations for this medication? It is a high alert med, so we need a 2-nurse verification. We need to have 2 nurses at the bedside initiating this med. You need to continuously monitor your baby and your mom when giving oxytocin. Okay, it is a very high risk Hold on one second. It is a very high risk medication. There we go. It's a very high risk medication that needs to be continuously monitored, especially from a fetal standpoint. Okay. We also need to stop or half the Pitocin, like I said, in case of the fetal distress, and watch for any for having too many contractions. Okay. Augmentation of labor is different than induction of labor. So, augmentating labor is whenever labor has already started and we're just giving more contractions or helping mom's labor progress. So, this is the stimulation of uterine contractions after labor has started spontaneously and is progressing unsatisfactory. So, if a mom comes in, she's in labor, and then her labor stalls, we're going to give her medications or do something to help speed have her labor pick back up. Okay. So, typically with an augmentation, we see oxytocin or we see providers rupture membranes for the patient. Okay. All right. Whenever we talk about vaginal delivery, whenever we talk about induction of labor or anything like that, we also need to talk about operative vaginal birth. Oh, hold on one second. Sorry about that. I had some technical difficulties, but okay. Moving on here, we're talking about our operative vaginal birth. Okay, this does not mean some weird type of surgery. It means a forceps assisted delivery or a vacuum assisted delivery. When we talk about operative vaginal birth, this is an assisted delivery done by a provider using forceps or using a vacuum. Okay, forceps are an instrument with two curved blades and it's used to assist in the birth of fetal head. It's not as common. Indications for a forceps delivery would be a prolonged second stage of labor and the need to shorten the second stage for maternal reasons, exhaustion, cardiopulmonary or cerebrovascular disease. Sometimes if baby is indicating it, so there's fetal compromise. What are the conditions necessary for success with a with a forceps delivery? The cervix has to be fully dilated. This should be obvious, right? We do not want to be delivering a baby with a cervix still present. Bladder should be empty. The presenting part needs to be engaged. Membranes have to be ruptured. Maternal pelvis size must be favorable for delivery, for forceps delivery. Considerations with the forceps delivery. Mom must be assessed for vaginal or cervical lacerations post-delivery. We have to watch for urinary retention and a hematoma formation in the pelvic soft tissue. And then the baby needs to be assessed for bruising or abrasions at the site of the forceps, okay? Forceps delivery and vacuum delivery are invasive, okay? You're putting a lot of pressure not only on the maternal pelvis, but also on the fetal head. So we need to assess mom and baby very thoroughly after these kinds of deliveries, okay? A vacuum assisted birth is that whenever we attach a vacuum cup to the fetal head, we use negative pressure to assist in the birth of the head. So it's basically like a suction cup. You put it right at the top of their head, and then you're going to pull as mom is pushing with a contraction. Okay. Prerequisites: you need to have informed consent. Providers need to get verbal consent from their patients before they do a vacuum delivery. Okay. Not all of them do. You'd be surprised. So that needs to be in the back of your mind. These providers need to talk to these moms about this kind of delivery and ask them if it's even something they are okay with. Okay. Moms need to be completely dilated, membranes ruptured, engaged fetal head, vertex presentation, no suspicion of cephalopelvic disproportion. Nursing considerations. We need to discuss what a pop-off is in our hospital policy. So typically, whenever a provider puts that kiwi or vacuum on the baby's head, they have what we call pop-offs. So usually hospital policy says that providers are allowed to use a vacuum and have a total of 3 pop-offs. So that's just what happens whenever the provider is pulling, 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 and then that vacuum loses suction on the fetal head and it pops off of the baby's head. That can only happen 3 times, usually, okay? If it happens more than that, the provider needs to stop trying with the vacuum and we need to do a C-section, okay? This is to protect the fetal head from injury, okay? If you're constantly applying that pressure and you're pulling on that head to the point where you're having this kiwi lose suction and pop off continuously, we need to start looking at alternative methods of delivery because typically that means that the baby's head is not coming down through the vaginal canal and it's not making progress, which is the whole reason why we're using the kiwi in the first place, okay? Risk for a newborn would be a cephalohematoma, scalp laceration, subdural hematoma. For a mom, we're worried about perineal lacerations and hematomas for her as well, okay? Why are we worried about hyperbilirubinemia in a baby after a vacuum delivery? Typically, it's because anytime a baby has bruising, excessive bruising or injury, they are at a higher risk for hyperbilirubinemia because their body is trying to compensate for the injury. It's trying to help heal that injury. So their bilirubin levels are going to increase. They're going to become jaundiced, lethargic, all of the things that we'll talk about whenever we discuss hyperbilirubinemia. Okay, so you need to know that. Here are some lovely pictures. These are forceps, different kinds of forceps. Here's what it would look like applied to the fetal head. This picture here is of a kiwi. So you see that little suction that goes on the head. They kind of like pump up. They add that negative pressure. It allows for them to pull on the fetal head as the mom is pushing. I have some not deliveries, some videos here that show you a version of forceps delivery and a vacuum assisted delivery, just to help give you like a good visualization of what these things look like. All right, let's move on here. We're going to talk about C-sections. Cesarean birth is the birth of fetus through a transabdominal incision of the uterus. It's typically performed due to maternal or fetal complications, but it also may be elective, scheduled, unplanned, forced, which we'll talk about that, okay? Indications for a C-section. Marfan syndrome, non-reassuring fetal status, malpresentation, breech presentation is one of the main reasons we do C-sections, okay? Active maternal herpes infection, failure to progress, abruption, placenta previa, history of a previous C-section are all reasons to have one, okay? Surgical techniques. We talk about the type of incision. So a low transverse is preferred and the most common. A T-shape or other vertical incisions are not preferred. If you have any type of surgical incision other than a low transverse, typically that mom is not going to be able or allowed to have a vaginal delivery after cesarean. She cannot VBAC, okay? The transverse or bikini incision is common. The type of incision is based typically on anatomy, urgency of surgery, fetal lie. If the patient, like I said, has a vertical incision, she cannot VBAC. Complications and risk for mom: anesthesia issues, hemorrhage, bowel or bladder injury, amniotic fluid embolism, bolus, air embolism, wound infection. For the baby, we are worried about injuries, higher risk of needing resuscitation efforts following delivery. And then finally, our anesthesia, spinal, epidural, or a general. Epidural is the most common, or spinal is the most common, so moms can stay awake throughout the procedure, okay? In an emergency, it's typically general anesthetic, unless moms already have an epidural in place, but still they may need to use general anesthetic, okay? Especially in a stat section, let's get this baby out within 15 minutes, okay? So we talked about the types of C-sections. So with a scheduled C-section, labor and vaginal birth are contraindicated. This is usually because moms have a placenta previa, they have active herpes, they're HIV positive, with the high viral load. This is a repeat C-section for them. Birth is necessary, but labor is not inducible. So they're not allowed or able to be induced, okay, for whatever reason. An unplanned C-section or emergency or stat C-section would be forced. No, an unplanned or C-section or emergency stat C-section occurs typically because of fetal distress or because of maternal distress. Okay, so there's some type of Something has happened in labor that has shown us that we need to take this mom back to the OR now. A forced C-section is when a mom is refusing surgical intervention, and then the healthcare providers are put in a really tough spot. So, your baby looks like crap on your monitor. We need to have this baby delivered. Your mom is refusing a C-section. How do you proceed? I have been in this position, and let me tell you, it is not a fun one to be in, okay? So, you need to take that in consideration whenever we're discussing with mom C-section versus vaginal delivery and let them know that like this is this is going to be something that could happen, and you need to be prepared for that if it does. All right, prepping our patients for a cesarean delivery. Prenatal. All birth prep classes should include education related to a C-section delivery. Not all of them do. So, as OBGYNs, we should be educating our patients on, hey, listen, it's all fine and dandy that you go to our birth prep classes that are offered at the hospital. However, if you know that they're not offering any education about C-sections, we need to tell the moms. Also, while you're researching everything, look into cesarean delivery, look into cesarean birth, because this is something that any mom who's going into labor is at a risk for. Okay? Before the procedure, we need to have mom sign consent. We need to make sure they remain NPO, draw labs, put on SCDs, do a perineal and abdominal prep, administer antibiotics, and remove any metal or jewelry. During surgery, we need to be communicating with our mom. We need to involve the patient and the partner as best as we can. If it's possible, have a window in the drape so that the moms can see when the baby is being held up after the baby's delivered. Okay. Timeouts and counts. If you're the circulating nurse in the C-section, you need to make sure that everything is counted before the start of the case. Immediately after delivery, follow your hospital protocol and policy. Typically, it's vitals every 15 minutes for 2 hours. Incision and fundal assessments along with the vitals, and then we're assisting moms with breastfeeding. Finally, postoperative and postpartum care. We need to monitor and provide for regular postpartum needs, okay? Just because they delivered from a C-section does not make anything different. So we're helping with toileting, we're helping with their ambulation, we're helping manage their pain. If anything, we're a little bit more hands-on with post-operative patients because this is a higher risk delivery, okay? All right, so let's move on. We're talking here now about vaginal birth after cesarean, which is our, excuse me, VBACs. So, vaginal birth after cesarean can be a very safe option and very manageable thing that women who have had C-sections can do. But it all depends on why did they have a C-section with their last delivery? How is this baby positioned? What is her Bishop score? How is mom's anatomy? All of that stuff. So we have to do a trial of labor after cesarean. This is what happens when we observe a woman and her fetus for a reasonable period of spontaneous active labor to assess the safety of a vaginal delivery. So while we have moms sign consent forms for a VBAC, we also need to make sure that we're monitoring them at the start of this labor to see, is this even going to be possible for moms, for this mom? Okay. We can only try a VBAC if her incision was a low transverse and she doesn't have any underlying risk factors or major pregnancy complications. What is our biggest risk with a VBAC? Uterine rupture is the biggest risk. Okay. And that's because we have that scar tissue that's built up on that uterus. So with the contractions, we run the risk of the rupturing because of that scar tissue. If that scar tissue is not going to stretch, it's not going to form around baby, it's not going to handle those contractions, we run the risk of a rupture. Indicators for a successful VBAC include if mom has had a vaginal birth, so she has a proven pelvis, she's had a VBAC in the past, and she goes into labor spontaneously rather than induced. What characteristics are less likely to have a successful VBAC? Recurrent labor dystocia, increased maternal age, gestational age over 40, maternal obesity, a big baby, or preeclampsia. Okay? So we talked about our VBACs, we talked about our C-sections. Let's talk about some OB emergencies or OB things that we can see that have a little bit more of it, things to do with the baby. So the first thing is meconium stained amniotic fluid. We've talked about this before. This means that the baby has passed meconium or the first stool before birth. The biggest risk associated with meconium stained amniotic fluid is infant meconium aspiration when that baby swallows and breathes in the meconium. Three reasons typically that we see meconium being passed in labor. It's sometimes a normal physiologic function that occurs with maturity or with breech presentation, result of hypoxia-induced peristalsis and sphincter relaxation. So the baby loses some oxygenation and has a bowel movement. Or it results from the umbilical cord compression. So, like I said, baby loses oxygen. They have that peristalsis and sphincter relaxation. They have that meconium. Okay. Another emergency that we're going to discuss is a shoulder dystocia. This is an OB emergency. This is a condition that happens in which the head of the infant is born, but the baby's shoulders are stuck in the maternal pelvis. Okay, it is a big time emergency. It's usually from size disproportion between the fetal shoulders and the pelvic inlet. Risk factors would be a large for gestational age infant, a history of shoulder dystocia, or if mom has any type of pelvic abnormalities. What are some indicating signs that we can see with shoulder dystocia? Slowing the progress of the second stage of labor, or if baby is forming a lot of caput, I can't say that last word, but caput. When that baby's head is molded and you just feel a lot of excess skin and you don't feel any of the baby's like bones of the skull. Okay. We'll see a picture of caput here later in this class. Why is a shoulder dystocia so dangerous? We see sometimes with a shoulder dystocia, especially if it's prolonged, asphyxiation. So baby is not breathing during this time. Can lead to clavicle fracture or a right arm fracture of the infant. Okay, so the biggest risk with shoulder dystocia and why we need to fix it immediately is because baby is losing oxygen whenever we're in that position. So we do not want this to happen for a prolonged period of time. What are our nursing interventions? We're going to talk about that here in 2 slides. First, I'm going to show you here a picture of shoulder dystocia. So you can see here's the pelvis, your pubic bone. Down here you have your baby, the head is delivered, and look, that shoulder is bumping up against the pubic bone. Okay? It can lead to brachial plexus injury, damaged nerves, like that clavicle fracture, arm fracture. It's very high risk. Okay? And we need to be careful with them. So here are our nursing interventions. The biggest one is we're going to employ 2 maneuvers that work really well. McRoberts and Gaskin. So McRoberts is when we bring mom's legs straight out and then we pull her legs abruptly back towards her chest. Okay, that's going to help try and dislodge that that's going to try and help dislodge that baby's shoulder from the pubic bone. Okay, here's a good picture of the McRoberts. So we're hyperflexing legs to the abdomen and we're applying that suprapubic pressure where we have a provider or a nurse push down on the pubic bone to try and dislodge that shoulder, that anterior shoulder. Okay, another maneuver is the Gaskin maneuver. So this is when we put moms in hands and knees. This is not the gold standard. This is like we're trying this after McRoberts because if a patient has an epidural, it's going to be really hard to get her in hands and knees. Okay, so McRoberts is the standard that we do, and then also we're applying that suprapubic pressure, like I mentioned. Okay, so you definitely know what McRoberts maneuver is, and we use it for a shoulder dystocia. Okay, this picture is a really good picture, so I would definitely use that when you're studying. All right, let's move on here to our umbilical cord prolapse. So, a prolapsed umbilical cord. We talked about this briefly last week whenever we talked about polyhydramnios, okay? This occurs whenever the cord lies below the presenting part of the fetus and is birthed through the vaginal canal before the fetal head, okay? Contributing factors. If a baby has a long cord, if the baby is not presented, if there's an unengaged presenting part. So, like that baby's head is floating up in space. You got a whole bunch of fluid surrounding the baby. The umbilical cord is dropped down underneath the baby's head, in between the baby's head and the cervical opening. You rupture that water, that cord's going to slip right out. Okay? Signs and symptoms of a cord prolapse. If you do not actively see the cord in the bed or in the vagina, or you don't feel it, baby can sometimes have variable or prolonged decelerations with contractions on the monitor. Women may report feeling the cord or feeling something in the vagina, or you just see it. You sometimes will see the cord. Nursing action. What do we do? What is our first intervention with a cord prolapse? We are going to change this patient's, we are going to relieve pressure off of the cord, okay? Because if that baby's head is pushing down, it's most likely pushing down on the umbilical cord and cutting off oxygen to your baby. So we want to put two fingers into mom's vagina. We want to lift up that presenting part off of the umbilical cord so that baby can be oxygenated again, okay? That is our priority intervention with an umbilical cord prolapse. Other things that we need to do. Stay with the patient. Call the provider and the surgical team. Don sterile gloves and relieve pressure of the cord. Place the patient in hands and knees or Trendelenburg. Trendelenburg now is kind of contraindicated because if your patient has an epidural, we don't want them in Trendelenburg. Basically, the idea is to just get that pressure off of the cord, okay? If the cord is protruding, we're going to wrap the exposed part in sterile towel with warm saline, administer oxygen, and give a fluid bolus. Here's the correct position that we want moms in, this knee to chest position, because it's going to use gravity to bring that baby down and relieve pressure off that cord. Here's what I mean whenever you don those sterile gloves and you're going to put your hand up into the vagina and put pressure on the baby's head to move it off of the umbilical cord, okay? All right, two more things to discuss, and then we have some case studies, okay? So, if we have a uterine rupture, that is a huge OB emergency. So, a uterine rupture is the symptomatic disruption and separation of the layers of the uterus or previous scar. This is very common, like we said, with a VBAC or a trial of labor after cesarean section. Risks would be if there's a scarred uterus from a previous C-section or other surgery, if the mom has had multiple C-sections, trauma, abortion, grand multiparity, uterine overdistension, instrumentation injury, or uterine perforation. All of those things are risk factors. Prevention. No labor attempted with a classical C-section incision. So if the incision is not a normal low transverse bikini line incision, we should not be attempting labor. Okay, cautious monitoring with oxytocin administration, because if we have too many contractions, that can cause a tired uterus. It can lead to uterine rupture. Signs and symptoms of a uterine rupture. You guys need to star, circle, highlight, do whatever you need to do, but you need to know this information. So, if you have an abnormal fetal heart rate tracing, loss of fetal station, sharp or sudden abdominal pain, if mom reports feeling a ripping or tearing sensation, if she reports bright red vaginal bleeding or signs of hypovolemic shock caused by hemorrhage, those are all signs and symptoms of a ruptured uterus. Okay, and what are we going to do? She's going back to the OR, okay, immediately for a stat C-section. Okay, last one we're going to talk about is an amniotic fluid embolus. This is rare. This is an anaphylactoid syndrome of pregnancy. It can occur during labor, birth, or within 30 minutes after delivery. This is what happens is there's sudden respiratory and cardiovascular collapse, coagulopathy, acute hypotension, and hypoxia. Oftentimes, this will lead to or be a result of a DIC, okay, which we talked about that. This is caused by a foreign substance introduced into circulation. So if mom is, what are some predisposing factors? Who's at a higher risk for developing an amniotic fluid embolus? Moms who've had a rapid labor, meconium stained fluid, uterine tears, post-term pregnancy, labor induction or augmentation, eclampsia, cesarean section, placental abruption or previa, or if mom has a lot of amniotic fluid. Okay. Treatment. We need to do something immediately. This is not something you just wait around on. We're going to give mom CPR. They're going to be in really bad shape if they throw an amniotic fluid embolus. We might also need to take into consideration a perimortem cesarean section after 4 minutes for optimal fetal survival and to facilitate maternal resuscitation. Okay, so these are pretty serious, and we need to be prepared if we were to run into any of these on the floor. Okay, all right. So I think what we're going to do is we're going to go over case studies in class because I think we'll talk about these um, more thoroughly together so that we have time to discuss them. So whenever you come to class for week 6, definitely make sure you have this PowerPoint pulled up because we'll start class by discussing these case studies that are at the end of this PowerPoint. Okay? That is all I have as far as the week 6 content for maternal and newborn nursing for Fortis College. So if you guys have any questions at all in the meantime, prior to class start, definitely message me on Canvas. But taking good notes on this PowerPoint is going to help you for your exam. Okay. Like I said, just reach out if you have any other questions or concerns. Thank you so much.